We'll start today's last session with Sheana, who's at the University of Colorado at Denver. She's been working in public health for 10 years, authored something like 40 or 50 scientific articles, and I wanted her to come talk about her work, not the results of the work, but collaborations and partnerships and how that has fit in and some things she's done along those lines. So please welcome Sheana.
Thank you so much for having me. It's been really delightful, and I have to say this really beats your typical academic conference, really. And I was a little worried at that introduction because I thought, oh no, they're going to think that I'm going to be up here presenting data, and I'm not. I do want to talk, though, about something that's really very dear to me and something I'm very passionate about. I've been hearing so much great work about design and iteration and being willing to try new things and getting things in front of your users, which I think is really important, and that's going to be a lot of what I'm talking about too. But at the end of the day, I want to go back to what was said in the morning. I'm a public health person, and public health people don't do their work for the money, unless I'm really missing something. But there's also nothing wrong with the statement that was made this morning. You can make money while you're making a difference. And so I want to think about what's all of this about is the scalability and the opportunity we have to make a difference. And that means making a difference in people's health and health outcomes. So when I think about collaborations, I think about who are my end users. And for a lot of times in public health, those are the people who are, at the margins. They're the poorest folks. They're the folks who are disenfranchised. So I think about why collaboration, and it's really about making the best product you can so that those folks who need it the most can improve your health. So I'll use some of BJ's language around the BJ Fogg behavioral motivation design. I'm calling it the wrong thing. And thinking about motivation, what would motivate you? It should help you to connect with people so you can design the best product possible. We've heard a lot about putting things in front of users and iterating today. That's great. Making sure it works as you intended, but making sure your end user can make it work the way that you intended. And then these last two bullets are really where I think we're falling short. We're not doing such a great job of demonstrating efficacy, demonstrating that our products work for the intended effect. Are they helping people lose weight? Are they helping people quit smoking? Are they helping people eat more healthy, get more physical activity, reduce their stress, use condoms? That's my field. And then finally, once you know that something works, what's the benefit unless everybody who needs it gets to use it? So learning a little bit more about dissemination and making champions who can spread the word. So when I think about collaborators, I think about who is affected by our greatest public health problems. And in this case, I think about collaborators as representatives of the intended audience for your product. So for me, I think about baby steps in collaboration are really about figuring out who's going to be using your product at the end of the day and thinking about how to get it in their hands before you even start creating. So the first part there is identifying, recruiting, and engaging your collaborators. So what are baby steps in identification? Everybody can do this right now. Think about your intended audience. If you've got a mobile startup that you're trying to get launched, just think for a moment, who do you want to see use it? Who would be ideal for you? Is that women? Is it men? Is it older folks? Is it adolescents? Is it a particular racial or ethnic group? And then think about who is connected to that audience. You may already have these connections. For me, I do work in HIV prevention and prevention of sexually transmitted infections. So I want to start in the beginning about thinking who reaches the most of those people possible. And in the United States, here's a few examples. Planned Parenthood, they've got clinics throughout the country. They've also got affiliates globally. So it's a great organization to work with. National Coalition of STD Directors, you may not have known there's such an organization. And I'm doing work right now with the Boys and Girls Club. So thinking about are there organizations that work on a national level or even a local level or a regional level that serve the audience that you want to reach with your product? And then thinking about, well, what's the next step is recruiting them, thinking about how to get them to talk with you, even before you really are starting your work with your concept. So academics in public health spend a lot of time in this process, or adhering to this philosophy we called community-based participatory research. And there's actually been quite a bit of research done on this process and showing how effective it is to collaborate with your user right from the very beginning. So one of the main principles there is don't wait. Don't wait until your product is already developed. Get them to the table before you have really started. Now, that doesn't mean that if you've already started and you're iterating that you can't bring them in. Of course you can, but next time, bring them in earlier. So one thing, of course, you can identify those organizations, and here everyone has this skill. Within your networks, you know people who know people that are part of the audience you want to serve. Also, for regarding recruitment, in addition to not waiting, be generous. So think about, this doesn't always have to be about money. Of course, money will help, but being generous really allows people to have a voice and a seat at the table when you're thinking about what it is you want to do and get out there. And it will pay you back enormously on the other end when they become your champion because they've been heard, because their ideas have been heard and they've been allowed to contribute. So once you've identified who you need to be working with or collaborating with, and you've recruited them to sit at the table, then you have to make their participation meaningful. And I'm going to introduce a way that we're thinking about this, and it'll bring back some of the conversations we've been having earlier. You know, I think a very real criticism and a valid criticism of academia is we take forever to evaluate things. So people in mobile health and e-health generally have a very valid criticism that, well, we can't evaluate and see whether or not our programs work because it takes too long. But I'm going to throw out a challenge to say, well, if we on the academic side can shorten our timeline and do this process more quickly to find out whether or not something is actually having the impact we intended, then people could do a better job of being able to use evaluation and get data that says not only do people use it and engage with us, but it's having an effect on their lives. So there's three ways that you can three places where you can engage, and we've talked a lot about these already. People are engaging at the concept level, you know, draw it out on a napkin and have people respond to it. Prototyping, you know, doing it iteratively, making sure that it's working the way you intended and that it's not breaking. And then maybe I'll spend a little bit more time here on the pilot, because that's really where we're getting more data on the end of, is it working to change behavior and then improve health outcomes? So in the concept, I mean, you've already been talking about this all day. You know, you can do this technologically or you can do this face-to-face. Get groups of people together from your intended audience and get them to tell you what they like, what they don't like. Now, of course, I do really appreciate the comment in the last session that sometimes you can be too wedded to what the user says, and this may thwart innovation. But at least you can get some initial feedback about whether or not people are going to be taking up or engaging with your product. Certainly prototyping and beta testing, you know, getting it in the hands of the audience. Once again, and I've heard this a couple of times, that people are reluctant to do this until you've got something that's working a little bit better. But trust that the person that you want to use it at the end of the day is the person who should be giving you this kind of feedback. And don't keep that just in your organization. You may have to give them the app or give them a device for a few weeks or maybe just even a week. So here on pilot testing, this is where you may need more of partnerships with university folks or other academics that do evaluation. There's lots of research shops that are not necessarily tied to universities where you can dial into some of this expertise. But this process should be separate from the actual use of the device in order to be able to document what it is that you want to change and that exposure to your device facilitated that change. So you can do a lot of this technologically as well. Now you can start pre-assessments as well as post-assessments to evaluate your program and get respondents. Of course, you can do this quickly now. This used to take us many years, if not longer, and we talked about that timeline this morning. You can do this very quickly now, and you can do it online. So a lot of the things that people in public health are looking at are behaviors related to smoking, fruit and vegetable consumption, anxiety, physical activity, and sexual risk behaviors. So, there's lots of survey tools that you can place this online. We're thinking now of getting panels and empaneling groups of people that we want to work with so that they can regularly take part in this iterative, rapid prototyping. Once you've got some pilot data that suggests that your program might be working the way it's intended, that's the time to go back to your partners and say, look, it seems to be working. Can you help us disseminate this? Can you help us get it in your clinics? Can you help us get it in front of your clients or the people that use your services? And that's what I think about when I'm saying designing for dissemination. In the beginning, when you're thinking about your product, you want to think about how to get it at the very end when it's working and when you know it's having an effect in front of as many people as possible, because after all, that's what the potential for all of these devices is. It's got an enormous reach and it's scalable. So you can use your partners, again, to kind of think back about dissemination and the plan for dissemination. There's several programs that are great and innovative, but actually few that have been fully evaluated. And the Academy needs to take responsibility for the fact that we do it so slowly that sometimes by the time our evaluation is done, the tool is obsolete. But I'm suggesting that if we can speed up that process and design for dissemination and have collaborations with our end users along the way, we'll be able to generate better products that actually work and have an impact in public health. Thanks.
And perfectly timed, too. Sheana, let me ask you a couple of questions, and we'll get to you, Robbie. What kind of pushback do you have from academics or scientists on this kind of approach? I think it turns on its own.
Is it on? Yeah.
Yeah, so I think that's kind of a question that people have, or maybe people in there are like, wait, but.
Yeah. So actually, it was in the last session where it was mentioned around, sometimes you can't always listen to your audience. And so if we listened to other academics a lot, the pushback is, oh no, unless it's a randomized controlled trial, it's not good enough, or unless you have the appropriate sample size, it's not good enough. I think we don't throw the baby out with the bathwater. There are other methods that we can use, and especially now that we have megadata and the ability to collect data so rapidly, we should really use those technological advantages to be able to really reflect on whether our designs can be updated to more quickly answer our questions about efficacy.
Well, this different, faster way of doing things, I think we'd both agree we sort of expect younger academics and younger scientists to be more open to this, right? Do you see kind of exceptions to that? Is there a surprise in that statement, or is that end of story, period?
No, I think there's surprise. There's always your, early adopter, and that doesn't necessarily correlate with age. Okay. And like you and I, we met at the American Academy of Health Behavior Conference, and there were a couple people there who are my elders, and I'm not a native, I'm not a tech native, who were very much in favor of exploring these new approaches. So I think there may be more conversations about it happening.
Great, thank you. Next is Robbie Pakter. Robbie is the founder and CEO of PillJogger. First speaker, I think, from Johns Hopkins. Got your MD there as well as your undergraduate. And you got a lot of cool stuff going on, including inventing medical devices and a previous stint as chief of radiology at Marin General Hospital, which seems a pretty big shift to today. So interesting background. Roby, take it away.
Thanks very much. It's really a pleasure to be here. BJ, thank you so much for having me. I've been on the road for the last couple of weeks talking at a number of conferences around Europe and here, and there is really nothing like a BJ conference anywhere. The level of detail, I don't know if anybody noticed, the balloons are changed each intermission. Let me ask all the entrepreneurs in the audience to stand. Okay, we're going to try something here. On the count of 3, all together, and my team as well, I would like you to yell out as loud as you can the name of your company, okay? 1, 2, 3. Great. Good job. For those of you who aren't entrepreneurs, that's what it's like trying to get your voice heard. And I'm going to take the few minutes I have to describe to you the road that we took from the time I left practicing medicine about 1.5 years ago to starting the PillJogger venture, and some of the things we learned along the way as baby steps, and I hope they'll be helpful to you all. You know, people become entrepreneurs for a number of different reasons, but there's a commonality, and that commonality is the belief that you have a vision of something that's going to change the world, and the world can't wait. So for guys like this, it was dropping out of college. For me, it was a little bit later in life, and when I was a fellow on this campus about 25 years ago, I had no idea I'd be spending a couple of days here in the B School speaking about my venture. So we all come with different backgrounds, but we all believe in it inherently, and we believe we have something that can change the world. So I was an interventional radiologist. For those of you who don't know what that is, imagine you've got somebody's life in your hands. You're in a dark, a pitch black cave, in fact, and you've got a flashlight that only works every few minutes. So you've got to figure out, literally on your feet, how you're going to get through this, and you learn a couple of things. First, don't panic, and the second is, if it's not working, try something else. The other thing you learn, and I really like this picture as far as what it's like to be an entrepreneur. This fellow here is not thinking about the small picture above his left shoulder. Because if he is, or if he were to be thinking about that, it would be a self-fulfilling prophecy. He's thinking about one thing, how he's going to get to the finish line and be number one. And so it's really no different whether you're an interventionalist like I was, or an entrepreneur, or an athlete. You're not thinking about failure, you're thinking about the success side of things. The other thing that's important is putting together a team that works together, like these great pilots in the Blue Angels, and I guarantee you the fellow at the top is not thinking about what he's going to have for dinner. So there were things I learned as an interventionalist, and there were things I didn't learn, and I want to share these with you. First, there are days as an entrepreneur when you feel like the gas might run out, and in the startup world, that's called capital. But you find a way to keep going and to try to keep the balloon afloat, even when the wheels come off. Of course, there are days when you go home and you have no idea what just happened. But as long as you keep to it, you'll climb the mountain. And that's what I think with my great team that I'm very appreciative of, several of whom are here, and hope you get a chance to meet them. Very diverse group, I'll tell you about in a moment. We're all committed to one thing, and that is the idea that we can change medical adherence. Medical adherence is a problem worldwide. It's a problem not just for countries that pay for all medicines, as well as in countries like ours where people sometimes have to come up with the money themselves. There are lots of reasons I won't get into about medical adherence. This is not really the topic of my talk here, but I wanted to give you a little background so you'd understand what our venture was. And the issue of who takes medicines is one that crosses all age categories. As you see on the slide here, even among adolescents, you've got a great number, nearly a quarter, who are on medicines such as medicines for asthma and medicine for diabetes. As we get into middle age, there are statins for cholesterol and hypertensive medicines. And as we get older, there's a whole host of things that people are put on. As you see in this picture, the older we get, the more medicines that we tend to be on. And it's really not talked about that much, at least when I was in medical school and when I was in training, that somebody comes in and you measure their blood pressure and it's elevated, and you put them on the first line of therapy. And they come back about a month later and you check their pressure again and it's still high, and you go, oh, okay, we're going to put you on another drug, we're going to add to it, and on and on. But really, what is only being appreciated now is chances are that person never really was taking the medicine anyhow. Less than 50% of people are adherent. There's lots of data on that. This is a study from the British Medical Journal that followed over 1,000 people, and if you look at practically any medicine, whether it's for asthma or CHF, cholesterol, etc., there's a drop-off called the cliff at about 90 days when people just stop taking medicine. So we had to try a new approach to solve this issue because of the unsustainable rise in healthcare costs in this country, which is fast approaching 20% of GDP. So the way we are approaching this is using smartphones. And when we first started the venture, a lot of people said to me, well, you know, old people are the ones on medicines and they don't have smartphones. But even in the time that we have been building this venture, the adoption rate is exploding, as you all know. Even in the senior population, the penetration is somewhere probably about 17 to 18% now. It's doubled in the last year. Tablets are very popular. Adoption is a very popular adoption for the senior population and families, so people can see pictures of their grandkids and such. But suffice it to say, we have a tool that can reach practically everybody. And the predictions are in a couple of years, there really won't be anything but a smartphone that you can purchase. So what was PillJogger? We tried to take a non-doctrinaire approach to a very serious problem. And we set out from the very beginning with certain tenets. Number one, it had to be easy. 2, it had to be somewhat fun. And 3, it had to be predictable in its unpredictability. So the way Google changes the doodle daily, on our platform we constantly change it and add the unexpected. We try not to follow the typical rules of gamification. And there are some studies now that show that gamification starts dropping off as far as people's participation after a few months. So we had to find something that really caught people's attention and kept the engagement going month after month, year after year. And what we came upon was something that already existed. What exists and what people are very adherent to, separating from medicine, are loyalty programs. And we're working with a number of entities that have existing programs that we can reach people with things that they want, not with things that they don't want. You know, this morning Robert Scoble talked about the kind of creepy factor of all the data that's being collected about us. What we hope to use is that data that can send something to you that is interesting and useful to you rather than something that you don't want. I won't get into that too much more in detail, but I just want to get into my baby steps. When we saw the standard types of platforms that were out there, we thought we'd have an easy time of it because we were very design-oriented and what I call the human factors on applications, which is something that everybody who knows about product design is important. And so we thought we'd get a response like this, but we really got a response like this. So we had to figure out a way to get our product accepted by the people that were important and by the consumers. So the first baby step was putting together a talent pool in our company, not just on the tech side, but also complementary. So we added a creative director to our executive board. Christoph Opperman is very talented, who can change, so we can change the design constantly. We want to remain fresh. And we brought in people with lifelong experience in pharma and some other things. So I recommend this to the entrepreneurs in the audience, that there may be additions to the team that you can call upon that you may not have thought of that can really make a difference in the longevity of the product. The second thing was get out there and meet as many people as you can. And coming to meetings like this is really very important. Eventually, you then do product demos, you might have booths, you might be a speaker, but it's really important to get to know as many people as you can. It seems rather obvious, but it's quite important. And lastly, we designed some products that I may not have time to really get into, but we think that can make a really big difference in adherence. So on the pharma side, we developed something called MedWheel, which is a patent-pending device where you plug in a cartridge with your daily medicines, and it's all there for you, and all you have to do is open it. For the payer side, we're developing a transitional care product to keep people out of the hospital once they've been discharged after diagnoses like CHF and such. And this will have embedded video. It will have our adherence module, because it turns out many readmissions are for medication noncompliance and medication errors. We'll tie that with connected scales and blood pressure cuffs and all the latest technology that we can put at our disposal, so that people on a tablet can have a very intuitive way of staying healthy, even if they've never been connected before. Thanks very much.
Hey, Roby, we'll have questions for you after Albert's talk. Albert Chen, welcome. I know you're not a stranger to Stanford. Awesome to be on the stage with you.
Thank you.
Medical director of Palo Medical Foundation, and also of My Health Online, which is an online service. The stat, and you may update me on this, is 72% of the adults actually use that online service, which is pretty great penetration rate. Welcome. Take it away.
Thank you. It's a bit of a reunion. I took BJ's class in like 2003 or 2004. I can't remember now. And
we were so young then.
yeah, I know. That is in my talk, turns out. So I'm going to just share a story about our experience, our baby steps over 13 years, but about delivering an online health record to patients. A bit about our organization. We're affiliated with Sutter Health, which is a large multi-specialty group and hospital provider here in Northern California. And I practice medicine at the Palo Alto Medical Foundation. We see over 750,000 patients annually. We were live with an electronic health record in 1999, and subsequently, in co-development with a company called Epic, developed a personal health record that's used widely around the country now, and that was launched in 2001. I think the temptation, though, when you hear a talk about electronic health records and personal health records, is to focus on technology. And I think that's the big mistake. It really is about the people and the people we're trying to serve. And so I'm actually really going to focus on that today, not the technology per se. But a brief diversion to myself. So I was a postdoctoral fellow here at Stanford in medical informatics. I was taking BJ's class. And there was this opportunity to work on a cool, what I called health IT project at the time, which was something very heretical at the time. Let's give patients access to their own data. Yes, they paid for that data through their insurance companies, and it is about themselves, but it was heretical to think that doctors would allow patients to see their own data, right? Anyone remember those times? And so that's what it was. It's been many nights. A very persuasive thought leader, Paul Tang, invited me to help out in this project called PAMF Online with folks like Barb Love, who's in the room today. And it was a project to queue up charts, because we had this belief back then that we had to clean up our mess before we let patients see their own data online, all right? And he said, okay, I'll pay you 1 minute per chart, and you'll be, because you're a quick doc, you'll be able to get this done very, very quickly. Turns out it took about 10 minutes per chart to do it right. I was still paid at the 1 minute per chart, right, thing, 1 chart per minute thing. And that's what it was, a very cool project, a very cool thing to work on. Until this man came into my life. His name is Kenneth Michael Cooper. When I started seeing patients at PAMF, it really changed my life. because this tool transformed from a health IT technology into something that really could transform the way I could deliver care. A brief intro about Mike. We first met after he'd had a stroke. So he had been a CEO of a number of companies. And try to imagine this picture. He walks into my office. We spend the next 40 minutes trying to eke out what he's trying to communicate with me via dry erase board. Because he had regained all of his functions and features of his bodily functions, except for the ability to express his thoughts. So he knew exactly what he wanted to say, but he couldn't say them. So let him tell the rest of the story.
My name is Mike Cooper. I'm 62 years old, and this is my story. I have been CEO of a number of companies. I have a wife and a dog, but 5 years ago, I had a stroke. I couldn't speak. I couldn't move my right hand side. I was wheelchair bound. When I got out of the hospital, it was important for me to meet my primary care physician and resume his care. He was going to do whatever he could do to get me back on track. One of the things that I use online is to message my doctor, and that's most important. I can also message any other doctor that I've seen directly. Either way, I have good information on what to base my decisions on. Right now, I'm back to normal. My speech is a little bit not as good as I would like, but it's going to get better. But I really want to be a CEO again. I'm Mike Cooper, and that's my story.
So how do you think his speech is like today, listening to this? Really, when we first met, he couldn't speak. He could try to conceive thoughts, but he couldn't speak. And we used this tool, this technology, if you will, to be able to communicate, to arrange for his speech therapy, to arrange for all the services that he needed to get better. And so that day, he thanks me for caring for him, and I thank him for changing my life. But this wasn't really possible just with technology, I don't think. It's actually something bigger than that. How many of you have had preschoolers in the room? Any, you guys have? Okay. So you've all experienced a biological ecosystem, right? Right. And you know, things like iTunes and other platforms are not just ways to buy apps or to sell content. They're really platforms for us to share ideas, share thoughts, and really innovate. And I think of these tools, electronic health records, personal health records, as platforms to do that, if you can create the ecosystem to support them. So many organizations may implement technologies like this, but as BJ mentioned, we've gotten over 72% of our active adults using this, and I'm going to tell you about how we got there. The first thing we really focus in on is, again, not the technology, but the value to all the stakeholders. So we really try to look at anything we implement and say, who's going to benefit? And if all the players in the room benefit, then it's going to work. But if you miss out on one of the key stakeholders, it's just not going to work. So for example, you know, in our example here, the doctors are very important. And many of you will be trying to implement technologies to affect patients and physicians. If you can't understand their needs as well and engage them, you won't be able to have a successful solution for anyone. Similarly, if you take out the organization, are there organizational needs you need to meet? And I'll show you some examples of how we've done that. And of course, most importantly, the patients, because that's what we're here for, the patients. So as BJ mentioned, we're all getting a little older now. Anyone know this man on the left? I know, random talk, technology talk. Cy Sperling. He is the owner of Hair Club for Men. And as I get older, I sort of appreciate his work a lot more. And the reason why I say this is I really try to eat my own dog food. My family comes to PAMF. I'm a patient at PAMF, and we want to try to develop solutions that we all can really use and enjoy. And because as I get older, I'm going to need these technologies and these services too. So, first part I mentioned is really the staff. And who are the people who really greet those patients at the front end? Who are the first people to contact with these patients? It's our staff. So we've worked very, very hard to get all their staff involved in our electronic health record and our personal health record so they could be the evangelists we need to be able to share with the patients to sign up. And because it's very important for them to understand what's the purpose so they can tell those stories about how it can help patients. Similarly, I got to engage the doctors. So I'm often tasked with developing a new solution, a new story to tell them about what it's like, new functions coming, and this is what they tell me they feel like. The pace of change is incredible, and that's what they feel like. So when you think to yourself, oh, I have this great solution that's going to make your life better, just think of this. This is what they're thinking inside when you're talking to them. So what I try to do whenever I introduce a new technology is say, remember what this is really all about. It's not about the feature or the window or anything you're seeing. It's about what we're trying to do for our patients. Would you ever walk into the room, besides our radiology and our surgery colleagues, would you ever walk in the room without a stethoscope? Maybe not you, but I think very much today, when I was interviewing for other jobs and I walked into one of the offices, they showed me, hey, Dr. Chan, there's we have this great file room of charts. I said, you got to be kidding. I'm never going to come here. This is what it's all about for me. Understanding what the doctors need is a way to engage them. And so what we've tried to do is design tools. So when patients submit online refills, for example, we change it from an online transaction, simply just signing a prescription, saying, here's an opportunity for you to catch the things that you would want to do for the betterment of your patients. So in this example here, this is a patient's on a medication. We want to make sure that all the information is there for the doctor to be able to more efficiently process that prescription request. And then there's simple competition. We're very transparent at PAMF about how people are doing, and we even compete on, so how many of your patients are enrolled online? So I'm very proud to show that I have 90% of my adults online. And then finally, the patients. We really want to become part of the community, and so we've really reached out in ways that are beyond the walls of our traditional brick and mortar clinics. We've put the little skins on buses. I was at the movie theater, and you're trying to escape with your wife from work, and I hear this little voice, and it's our ad. I think, God, okay, we're really in the community. But it's a neat thing to be able to reach out and become part of that community. So once you've achieved that engagement of all these stakeholders, the patients, the physicians, the staff, what can you achieve? So we've already mentioned that 72% of our patients, our active adult patients, are online today. We actually are able, even though our physicians are getting tremendous amounts of electronic messages from our patients, we have a 92% turnaround time within 1 business day for those messages, and an average turnaround time of 2.5 hours. Again, because we make the point that what we're trying to do is serve our patients, and that's what it's really all about. And this is actually a neat stat that I like to show. We also have been providing this service via our iPhone and Android, and we even get downloads from Paris, France, which is pretty amazing. I don't know what our patient was doing there, but there they were. And how many of you gone to a doctor's office and said, oh, there's this wall chart that says, I'm 40 years old, and here's my recommendations, right? You've ever seen those sorts of charts that recommend sort of generic things? I think healthcare is about persons and families, individuals. So what we try to do is take recommendations that are standard and actually personalize for the care experience for the individual and send that via our online patient portal. On top of that, we try to reduce barriers for them to do the right thing. So in addition to saying, here's the static view of what you're due for, we actually send a personalized message that says, I know you're due for that cholesterol test, and by the way, here are the lab and the lab hours. Just go ahead and get that done. Try to remove those barriers. When you do things like that, you get graphs like this. This is the population of patients who are not online, and the green one is the patients who are online who get this personalized message. What we saw is a 20% increase in adherence to those recommendations, and for invasive things like mammograms and pap smears, 3-fold increase in compliance as well. And we continue to reach out to our patients even on web. We send them information about if you need an appointment with urgent care, we actually tell you what the wait time is, so you can very efficiently figure out where you need to go at any of our number of our care centers. And now what we do is actually offer online services. And as I remind our doctors, this is about breaking down the access to care, the barriers to care. These little spikes are Mondays, but you'll notice even on Saturdays and Sundays and Christmas, we have people being able to book services even though there's not someone on the phone answering an appointment request. So that's a pretty neat thing. One final thing I'm going to talk about is how you bring this all together. So here's an example of innovation we've done most recently. What's more important than screening our children for healthy development? So what we've done is taken a paper process that was inherently paper-based and prone to error. You could very quickly in a busy day miss those things that the patient or the parent circled to tell you that there's something wrong. So instead, we've actually send those questionnaires to the parents online, and they fill them out, and we take that data and make it a structured format, and now it's a safer event because the doctors can actually document what's wrong and how they advise them. And the doctors have saved up to 4 to 6 minutes per those encounters, more time for the patients and parents to be able to talk about those concerns. That has led to questionnaires response rate of over 80% and over a doubling of engagement with our parents. And finally, I just want to I know I'm over time, finally, what we're next doing with this ecosystem we've built is really trying to engage our community. So I'd like to invite all of you. One of our biggest projects now is to work on successful aging. What are the barriers to aging gracefully and successfully in your homes and your communities? Developing signals to figure out what are some impediments to health. And we're actually engaging developers to try to help us rapidly develop solutions with us. So we invite you to look at our website and join us. And if you have a QR reader, you can hit that. Thanks very much.
We will take some questions from the audience in a minute, but I'm going to ask a hard question, and I'm not sure I have the answer to this. In the university settings, we are trained to be an MD, we are trained to be a research scientist. Here at Stanford, there's a D school where people are trained to design methods. If you take my class, you get trained in what I call behavior design, persuasive technology. We're not, at least in our education, formally trained on how to get buy-in and collaboration and do those kinds of things that really might be the limiting factor in having impact in the real world. So my question to you guys is, where should people be getting this training? If not in the university, where can it happen? I mean, you've figured pieces out on your own, I guess, or tell me where you got trained. And I guess we'll start with you, Sheana.
Well, I would say within public health there are a couple of kind of academic curricula, and we call them these things, and you could call them something else. It's just the label we use. We use things like cultural competency and cultural humility, as well as community-based participatory research. And they follow these principles that are basically, relationships and how to extend yourself to people that you need to be working with. And there's some science, there's actually quite a bit of science behind the community-based participatory research approach. Yeah. So some of those strategies exist within academia, but I think just like this, you just have to get out and practice them, because the academic isn't necessarily so comfortable with getting out and getting in front of people.
There's a reason people are academics, just like there's a reason people are engineers, right? Talking about the internal, getting the buy-in and so on, what's the difference between succeeding and failing, and how do people learn to go on the success path? So let's do Albert, and then Roby, you're next.
I think first thing is try to remember that, who in this room has a mother or father, right? Okay, right. That's what I try to remind people, that we are all, in my business, certainly all patients, and really try to walk in the shoes of folks that need the services that we're trying to deliver. So it's not an abstract concept, it's a real thing we're all living on. And actually, I do credit BJ for this. I read a book called From Cialdini about persuasion, and it was actually more informative of some of the things I learned in med school, to be honest.
Interesting. Roby?
Yeah, I think that it's really hard to teach inspiration, but inspiration happens spontaneously in the appropriate setting, in the healthcare setting, and the best that we can do is to try to assist with some form of innovation funding from the universities or hospitals, or what Palo Alto Medical Foundation is doing. I think that's fabulous. So when somebody does have that inspiration, there's a mechanism to enact it.
One of the speakers this morning, and I forgot who, we've heard a lot today, haven't we, said you'll probably have to do it nights and weekends. So maybe at the early stage of a project or an idea, or when you have the passion around something, you may not be able to get buy-in across the board. But I think we heard that message. You may have to just do it on side time, which is something so I've lived both in academics and industry, and I've lived in both worlds simultaneously for a while. And nobody comes to me and says, BJ, come in, as a new hire, come and invent something for us when I was a young person. You have to kind of go in and do it on your own time and trot it back in later with some evidence. Whereas my students think, I want to be hired to be an inventor. Hire me to be an innovator. No company's looking for somebody right out of college to do that, or very few. Let's take some questions from the audience about baby steps, collaborations, partnerships. Pam, we're going to start with you. Pam comes from an academic background. And then we will go. Yeah, Kara's bringing the microphone to the front. Just to get a finger on the pulse, how many people feel like in your work and your projects, getting buy-in either internally or finding the right partners externally is at least 50% of the issue you face in moving forward. I'm overwhelmed. I knew it would be an issue, but I'm kind of, that's wow. I just got a little bit of chills right now seeing that. Pam.
I sort of have two questions. One is many of the academics here, we've been having conversations during breaks about collaborations across institutions and across among academics and sharing resources and pooling resources. But another so we can comment on that. But also, I'm wondering as a researcher trying to get into this area, how can I partner with industry? And what are are there models for partnership between academia and industry in health promotion, things that may not be profitable in the long run?
Yeah. After we wrap this panel discussion, I'm going to show you a very quick, I call it a launch. It's not a launch in quotes into starting to understand that space. So I'll have sort of an answer for that, but let's turn it to our panelists, especially those who are on the side who are, MD. Opinions?
No, go ahead.
Point of view?
Well, it's funny. My mentor, Paul, often talks about it's finding the who, not the what, actually, because you find the right people, the solutions are out there, and the people who can help you solve those problems, if you work together, you'll find them. And I mentioned the developer challenge. What we're really trying to do is find that right person, that right team, and we're going to have a 6-month direct engagement with them for that right team to work with us, to try to figure out, can they look outside of us and have a fresh voice? Can they help us care for seniors in ways that we've never done before? I think there are many companies, and you're starting to see this with Health 2.0 and other things, where people are really looking for these opportunities to collaborate. So I think we now have a more fertile ground for us to be able to do that sort of work.
Yeah, and what's happened really over the last year or so is a number of companies have realized that solutions can come from the entrepreneur community, and they're funding these initiatives like the Janssen Healthcare Challenge, also from the government with the Surgeon General's Healthy Apps Challenge. And there's a lot of funding that's available to get into the academic world as well as the private world.
I would only say something to your first comment, and that is Ida still here? Ida Sim?
I saw Ida in the back.
So I don't want to out Ida in something she might not be interested in doing, but we just started a conversation over lunch, and I would say get in contact with Ida if you're an academic who would like to pursue this idea that I'm going to steal from Eric of agile science, where we're really trying to address the timeline, get things out more quickly, have effective evaluations that can be meaningful for developers.
That is so important, especially, and we had some of the discussion last year around health and how mobile and technology is changing so quickly, and the traditional scientific and academic ways of studying things just doesn't really match with the pace of what's changing in the real world. It's a huge mismatch. So finding the solutions there is a big deal. Other questions? Yeah, bring a mic here and bring another mic to the front. We'll take your question now.
I'd love to hear some perspective around how to address the cultural difference between two organizations. I'm with a large health plan, so we often have partner with vendors and companies to try to develop new solutions. But what we run into is two companies have very different culture. And you have two group of people trying to do something together, but they have very different paradigm. Yes, the top has made a decision, yeah, we're going to do this is exciting, but then something break down along the way. So I'd love to hear some thoughts on that.
What kind of initiative would be an example of what you're...
I'm with Premier Blue Cross. We have health plans, so we would partner with vendors like startups that try to launch something together. But that's the cultural shift and paradigm that we are dealing with. Does it make sense?
Yeah, as a startup, I would say it's up to the startup that you're dealing with to try to satisfy the wants and needs of the organization, and not vice versa. And I would say even not in the startup community, you're not going to stay in business too long if you bite the hand that feeds you. So if you're getting that level of difficulty and dissatisfaction, perhaps it's the wrong match.
Other comments?
I showed some examples. I think it's really, if you can unify on what you're really trying to solve and focus in on in this case, the patients, then you can usually find some common ground. And if you can't, then that's probably not the right partnership, honestly.
I would also say we experience this within organizations. So, at the School of Public Health in Colorado, what we're dealing with right now is kind of a disconnect between what the faculty want and what the IT think they want to deliver to the faculty. And so we're going through that, but it's a process of getting on the same page about what the goal is, and then identifying people's strengths and moving forward from there, I think.
Yeah. And let me speak to that a little bit. So, running an academic lab here at Stanford, I get approached often by companies who want to collaborate with my lab. And we did more of that about 10 years ago, and just found that probably mostly my fault not understanding the context around the goals of the startup or the big company and the academic goals of my lab were just not aligned. And it wasn't a great marriage. We had good outcomes, but it was sort of like, the company wanted this and we wanted that, and so we sort of backed off from that. And then I went to, shall I name names? No. I went to the head of a kind of big design group here at Stanford and said, how about if I hand off the people coming to me that want to collaborate to you? And he said, well, we really don't do many of those. And he explained exactly the kind of thing I was thinking. So I think if I express more clearly what we are looking for in collaborations, it's really about training students. That's the mission of the university. And there's certain projects where if you can facilitate gathering clean data for us, awesome. And there's nothing we can do that we want to keep proprietary. That's not the mission of an academic lab. So maybe we'd have a bit, but that's taken a lot of effort, and we've just kind of not done it. We've sort of missed opportunities, and I think there is a mismatch between what academic labs want, at least the way I run mine, and what industry people want. And I get that, because I also work in industry, but when they come to my lab and they basically think we're a consulting group, it's just not what I want to do. I don't know if you have that as well. Other questions? We had some in the front.
This is for Dr. Chan. I was interested in both the video and the image of the gentleman writing the direct question to you about something. And I was wondering, when you talked about getting buy-in from all the stakeholders, to what extent was there any initial resistance on the part of medical staff to the idea of the potential of the end of the day, and they've got 5,000 emails to respond to from patients? Was there resistance to that whole idea?
There's actually a real reason why I put Cy Sperling in the talk. It's because that sort of angst has caused me to need his services, probably. Of course there's resistance, and folks are working hard every day and we are seeing incredible utilization of this. To get some sense of it, we've seen a 4-fold increase in the past year or so in the volume of emails we've gotten from our patients. So it is a real challenge for all of us. What we try to do is talk about what are ways to set expectations between the patients and yourselves, set care expectations. And I found that if I set those expectations up front with the patients, they understand. And many times what the doctor thinks they want is not what the patient really wants. So if the patient just really wanted to hear, I wasn't sure if I need to come in for this or not, can you just tell me? And if the doctor got permission to say, yeah, that sounds like you need to come in for that, that's all it took. And so it was a lot less stress on it. But for sure, it's an ongoing challenge. Some of our docs really embrace it, and it's not really an age thing. It's just some of our docs embrace it and some don't. The folks that really embrace it well, and I have some other physician colleagues in the room who use the system, to the extent if you really understand how to use it well and actually adopt it and embrace it, you actually get much more benefit out of it than if you didn't.
Also, it's going to be compensated fairly soon. Is that your understanding from Medicare? Email?
We all hope that eventually that sort of work will be recognized, yeah.
There's a question in the back.
Well, my question was really along that same topic, was for Albert, was what conditions were in place, or did you set in place to make that viable for your physicians to participate? Were you in a total cost of care model? Did you negotiate reimbursement? How did you get the pieces aligned? What baby steps did you take both internally and with your external payers and partners to make the success you've had, because it's incredible success in terms of getting the physicians to get the patients engaged that way. But I think for a lot of the providers we work with, there's this belief that there's these barriers around the reimbursement models and these other challenges that are making that not possible or practical for them to justify.
First of all, it was 2002 and on going on. It was it's a leap of faith, frankly. Like many of you in the room who are entrepreneurs, it's a leap of faith. You have to just believe it's the right thing, and when your patients like Mike tell you it's the right thing, then that helps reinforce the right behavior. We are not in a total cost of care model. We're in a hybrid model where we have fee-for-service patients and we have some capitated patients. So we've just decided that we're going to differentiate ourselves in terms of service, and we're just going to deliver a quality product for our patients, and that's what will ultimately, at open enrollment and other times, they'll stick with us. And we just try to focus on that. We know that's a lot of pressure on our docs. We recognize that. We try to build tools in so that the messages that can be handled by other staff members are handled by other staff members. And we do try to align incentives to try to support them, to at least recognize the work that they do, even in the absence of recognition of this sort of work by government and other payers.
Question over here.
One of the greatest resources in terms of gaining compliance, both with patients and physicians, is utilizing the nursing workforce. What have you guys been doing to grab the nursing workforce and get them on board and get them to share this with patients and to teach patients?
Well, that's a great question. In our transitional care module, that will be integrated with the hospital's nursing staff that are dedicated to that aspect of care. So the way it works now is when you're discharged, for those who may not get the background, Medicare is going to, as part of the Affordable Care Act, Medicare will no longer be paying for readmissions for certain diagnoses. That puts $17 billion on the hospitals that they foot the bill. So they're all employing nurses to call patients and make sure that they're doing well and taking their meds and weighing themselves and such. So they would be an integrated part of our platform. So the patients would be able to tap to have a chat with them, live chat, or to email and such. So they're still an integral role.
Sheana?
I would say I know that there's a lot of emerging information from developing country settings where they're really harnessing the power of community health nurses as well as lay health workers who can be in more remote rural settings where it's much more expensive to have a doc. So they're using technology for surveillance, for collecting health information, sending it back to central servers, getting information about triage and pre-planning care and things like that. So developing country settings have a lot to teach us about how to implement some of these things as well.
We'll take Albert, and we'll take one more question over here.
I find the power of words pretty amazing. So one of the things we did at PAMF is we changed our online patient portal to not say message your doctor, but message your care team, to emphasize the fact that the nurses and the other members of the team are really, really important. We had a huge initiative I flashed through quickly in terms of time, but Barb Love and I and others worked on a campaign where we tried to enroll every staff member in our service so they could experience it for themselves, and then therefore they could share with others.
Interesting.
So I just have a quick
Eric.
question, thanks, for the whole panel. I'm wondering if you could just, if you have any examples of kind of speed dating but for collaboration, if you have any examples of how that might have worked, because I kind of feel like an interesting thing is knowing how to test out if a relationship is going to be good or not. And so if you have any examples or any thoughts on that, I would really appreciate that.
Okay, before you guys answer, let me kind of premise this. So when we thought, let's do baby steps for the conference theme, of course, baby steps in behavior change, which is something that I've worked on a lot. Baby steps in innovation, I've worked on a lot. But when the third thing emerged, and what's interesting, it feels like we've struck a nerve with this, baby step in collaborations and partnerships, speed dating. The first two I've worked on a lot. The third one, I've really not. I think it matters, but I don't have a great answer for that. What do you guys, how would you answer that?
Well, I would say we've had a couple of failures, where a relationship really kind of fell apart, and it feels terrible. You have a lot of conflict, and everyone feels uncomfortable. So that led us to a couple of points of philosophy. One is transparency, and acknowledging that everyone wants something from the relationship, and that's okay. But getting that out in the beginning to say, you know, this is what I'm looking for. Is that going to work with you? That's one step. And then to agree up front that an amicable divorce is fine. If at the end of this particular collaboration you don't want to go forward with another one or it doesn't make sense to, it should be perfectly okay to say, we did great work, thanks, and we're going to go a different direction. So if those things are okay to do, like BJ gave us permission to talk to one another today, it's kind of, you have to give each other permission to do those things that you may think are socially unacceptable, but I think they contribute to better partnerships.
Actually, this is being done now. Last week I was in Berlin at a conference that the director had speed dating tables with members of industry, that was members of pharma and payer groups, et cetera, and the entrepreneurs just moved from table to table. And there's an upcoming event, any entrepreneur in the audience may be relevant to you, Bay Bio. Has regular events, and there's a speed dating event coming up in the next month or so. So look on the internet, and you can find these things, but people are appreciating the value of this, exploring collaborations very efficiently.
What's the name of that? You don't go speed dating.
I think it's Bay Bio. I think that was the one. There are a number of, there's a number of entities around the Bay Area. I think VLab is another one, but I don't think they're the sponsor of this particular event. I believe it's Bay Bio. If anybody wants to, my email is robert@PillJogger. If you want me to look it up after the conference, I will, and I'll write you back with the info.
Yeah, and all this talk of speed dating makes me want to know about your life's work a little bit more, I suspect, and prophylaxis. I've actually really been impressed with the ability to set the goal, set the parameters, set the rule that it's okay to throw things away that you've tried, and just bring people together and say, here's the mission, let's get together in a room, let's lock the door for a day and see what we can come out of it, and then go from there. Take the best idea that comes out of it and move forward. So I think that's, try and try again, right? Why not?
Let's thank our speakers today. Thank you. Thank you. Stay here. Stay here. We have two more things to cover. One is I'm going to show you what I call a crummy trial, and it relates to the speed dating, it relates to this, it relates to just, so let's get the slides up. I'm going to tell you a story of something that mostly I take all the blame for the failings in this, did in the last couple of weeks. Oh, I have to push this button. This is why I have teaching assistants. They solve all the tech. Thank you very much. All the tech problems for me. When I say launch in the next few minutes, I'm not really meaning launch. I'm meaning putting it out there and see what happens. One of the needs I've been feeling for a while is you've got these skilled scientists and researchers, and then you have these startups, these small projects that are getting out there in the world around health and generating amazing data. But first of all, they don't know how to do it perhaps in the right way, and they don't know how to analyze it. And the bridge isn't there between the two. And because I have a foot in both worlds, it's like, I get that there's a ton of power in doing this research around behavior change and gathering the data. And then the scientists have, as academics, we have a different way of doing things. And how do we bring that together? So at a few venues, I brought up the question, how are we connecting it? A lot like Eric brought up and other people have. So I decided for this event, I was going to try something as a way to show you, hopefully show you, and you're probably going to be way unimpressed with this. So set your expectations really low of how you can go out and see, is this worth pursuing further? And I'm going to be really transparent about what I did in the method. What I find in working with my students, the more I try not to pretend like I know all the answers, and the more transparent about how would I think about this, and I made a mistake here, no, that was kind of crappy, and so on, the more they kind of feel empowered to step up to the plate and do it too. Like, it doesn't have to be perfect, and that's part of the method to my madness here. So I thought, well, how do we create a service that matches these people in some way? So I thought, well, what would be a good name for a research match? Not available. One that was researchlist.org, okay, researchlist.net and .org available. Buy those. Bam, bam, $18. So then what? I really didn't have to do that step, but I was just, it's always interesting. What would we call this? Well, the next step I took, And I'm not saying this is awesome. I'm saying this is fast, and I call it a crummy trial, admittedly crummy. Go into Google Docs, create a form, fill in the form. If you're not using Google Docs and if you're not fast at this, get fast at it. It's super, super helpful. So I created this thing, you know, this form basically. It's sort of a survey where I write, hey, do you want to, innovators, do you want a scientist to help you understand whether what you created works or not? And I guessed at what the questions might be. You can see right now, when I created the form, it has no responses, 0. I get the URL for the form, I post it in Bitly, and I'm a big fan in customizing the URL, and in this case, I decided to call it Research for You, bit.ly/research for you. And then guess what my next step was? Well, I wanted some, no hits on the link. Next step was post it to Twitter, write a tweet. So all of this takes, what? I'm probably at 15 minutes at this point. Health innovators, do you want help? Bam, put the link in. And then, within a few minutes, and you can kind of see what's going on, in Bitly and other kinds of link shorteners, notice I didn't write any code, 0 code, all off-the-shelf components. I'm a big fan of that. I think Manu was right. Before you write code, you have to think clearly about what you're doing. This, writing no code and getting out there, helps you figure out what you want to do. So, you know, 19 people have clicked on the link. A few minutes later, somebody actually fills in the form. I blocked it out with gray because I don't have that person's permission to show. In fact, at the time, it didn't dawn on me for a few days, people, a company that's doing this kind of work, a startup, they probably don't want to be on a public list. Hey, we're looking for a researcher. We don't understand our data, right? That probably needs to be confidential. That's something that didn't dawn on me as I was writing the form, and even on today's form, it's not there. But if we move forward on this, there's going to have to be some, I guess, assurance of it's not Craigslist where anybody can see it, because it could be a risk to your company. If people say, great, you look good, but you have no idea what you're really doing. Anyway, so at least one person liked it pretty fast. 35 minutes after launch, I went back and looked at Twitter, and there was a few people retweeting it or commenting on it. It's like, okay, it's not a complete 0. After an hour, I go back to Bitly. What's going on? Boom, you know, it's kind of, you know, being retweeted, or people are looking at the link. I did not expect it to go viral. I think almost nothing in health is going to go viral. There's reasons why people share things, and what health interventions about, they really don't match those reasons why people share. So what I was looking for is at least some people are going to click on the link. It intrigues some people, and yep, that works. So, you know, I was cranking out a whole bunch of other projects, coordinating with the speakers, working with Tana, but I took the time to say, well, it's going okay. Here's probably the next step. So this is my phase 2, and this is the phase 2 document. I just took a quick shot of it. Spam chat people. That probably means nothing to you, but the people that I've talked to over the years, there's probably about 1,400 people that I've had quick phone calls with. Pretty good audience for this, because a lot of them are on one side or the other of the equation. Email so-and-so. This is a scientist person that has access to other scientists. And I thought, let's get his response. I blocked it out because I don't have his permission. And then set up a simple site. And I just jotted that down and stored it. Went to bed. Woke up the next morning, looked at it. OK, 6 people have signed up. Great. You know, didn't expect it to go viral, but some other people have found it. I looked like what's going on Bitly, 111 links. There you go. On Bitly, you can drill down and see who's looking at it. Mostly people from the US, a few from Canada, and so on. So it's giving me a sense of, yeah, people seem to be interested, at least to a degree. And then Bitly also can capture for you what have been the tweets or conversations around it. Again, it's informing me in a qualitative way what people think about this. So that morning, I decided to tweet again. So the only work I've done so far is set up the form, tweet. That's it. Look at what's going on Bitly. I wrote this tweet, and I was like, I don't really like that, so I rewrote it. Not sure why, but I just wanted to show you that, you know, you think for a couple of minutes. You don't think for hours, but 2 or 3 minutes. What's the tweet? Is that the right thing I want to get out there? Boom, get it out in the world. I went back to the form and changed it. I realized I had made a mistake here, so I went back to the form, changed it, which is one of the things I love about web-based stuff. You know, you're not making a huge commitment. If you make a mistake, back up and change it. and posted it. And then this was interesting to me. Somebody from Sweden said, brilliant idea, might steal it for Sweden. Do you want a research scientist to measure impact? Which to me is a great sign. At this point, we're talking innovators and researchers, and I thought, let's start with the innovators to see if they're interested in research talent. Let's just start with half of the equation. So when I saw this so quickly, somebody noticed it, and I don't have other screenshots of this, but other people have emailed me and signed up on the form, so there's the beginning of some evidence that researchers are interested in crossing this bridge. I go back to Bitly again that morning. Okay, 138 clicks. 6 people have signed up. Looked at what the tweets, again, kind of just informing my sensibility of what's going on here. Adam Dole points out, yeah, you're right, there's a major gap in this. Adam's not here today. He's come to other events. And just looking at what people are posting on Twitter around it. Then I sent an email to somebody who had tweeted it. So I thanked this person for retweeting. And I said, here's some of the things I'm thinking about, hadn't thought about yesterday. Researchers may want to know whether it pays or not, whether they can use the data in publication, and so on. What's the start date? Again, I'm kind of figuring out what might matter to researchers. Again, this is not rocket science. This is kind of stumbling along. Very lightweight. I send an email to somebody who has a way to distribute to a bunch of scientists. I blocked it out, but asking for that person's thoughts. Check Bitly again later. More people are clicking through. Where are they clicking from? So you kind of get the idea. I didn't think too much. I didn't write any code. The investment's very lightweight. I just go back and peek at Twitter, at Bitly every so often. Not spending tons of time. It's like a minute or two at a time. Yeah, the email took a little bit longer than that. And then decided to retweet at 3 p.m. The first tweet was like 6 p.m. Pacific time, which is like an awful time to tweet. But I was like, whatever, let's just get it out there. Tweeted this, went back, look what was happening on Bitly, started watching some of the reactions, got somebody who emailed me about it, who was a researcher. I said, hey, what do you think about these issues? So, kind of, N of 1, getting a sense of things from this person. Then everybody who had signed up, at a certain point I thought, well, I can't just let these people sign up and leave them in the dark. I need to say, work in progress, I'll get back with you, which is kind of where we stand now. And they responded back. Again, it's just still tracking. I haven't retweeted at all. So the total was 3 tweets, almost 300 links at the time. Fast forward to today. So again, don't expect huge stuff, right? This is like crummy trial. So we have 20 people who have now filled in the form. The total investment was maybe about 30 minutes, $18, 3 tweets. And I know something. I don't know everything, but I have a sense of, okay, I think I can get innovators to sign up. Great. Seems like researchers might be interested. Great, I've got to reach out to them somehow. How do we put the two together in the future? Well, guess what? I'm not going to write code to do it from the outset. It's probably going to be done manually, maybe by me or somebody in this room or a small team of us. If I had to guess, I would have 3 people volunteer to do it for 3 weeks, playing this matchmaker between researcher and innovator, and see how that goes, right? And maybe try to do it with a couple dozen people and see what happens. And if it seems to succeed, then, well, do we scale it? Do we not scale it? So that's, it's this kind of thing that I find companies very resistant to doing, and it's this kind of thing that I really hope my students can learn to do really fast, because you discover things you would not have discovered sitting around smart people talking in a room, and you actually have some evidence. So if we're looking, actually somebody came to me and said, BJ, do you need funding for this? And it's like, no, I don't need any funding for this at all. I can get to a point, understand the landscape better, and maybe do the whole, and it wasn't like startup funding. It was sort of a foundation wanting to support it. But I now actually know kind of something. So I hope it doesn't shock you, the 20, how underwhelming that is. I hope it does encourage you to do stuff quick and learn. Now, if I decide this isn't going to work, I would just email everybody, the 20 people, and said, you know what? It's not going to work. We didn't get enough traction. Or guess what? The academic scientists don't want to work with you. They think your data is too dirty and not publishable. But I'd know something. So I'm a big fan. I have this phrase, many crummy trials beats deep thinking. Many crummy trials beats deep thinking. So what we could have done is had a conference and had smart people come and sit around for 2 days. How do we create this service? We could have thought and thought and thought. We could have written up a proposal. We could have gotten funding. We could have rolled it out 6 or 8 months, which might even be ambitious. I think that's the wrong way to do this kind of thing. Just dive in and try it. And if I were teaching a class right now, I would have said, hey, you, all the students, all 20 of you, start something like this. You each do it in a different way. Let's come back in a week and see which way looks the best. Start 20 crewmate trials. So that's, so I kind of, trying to be transparent. I'm not pretending this is great, but I hope it encourages you to just dive in and try stuff like this too. It is surprising how much you can learn for so little investment. All right, that said, we're gonna do one more thing and wrap for the day. I want you as tables and we're gonna just take 2 minutes to do this, and I'll hopefully chime you quiet, and I'll give you a final send-off into the reception. What has been the most surprising thing for you today? So day 1 mobile health, we're wrapping it right now. What's been the biggest surprise? Take about 2 minutes, talk about it as a table. Again, this is really fast. You're not gonna come up with the perfect answer. But what has surprised you most, okay? Ready, go. One more minute.
I'm not there yet. Oh. Okay. Okay, so, I'd appreciate it if you could hang on just 2 more minutes. Okay. Great, thank you.
Safe. And you can escape. There's some doors so you can get faster out.
Is it when?
How did it go? Were you surprised by the surprises? How did that go? We're going to move this into the reception, which starts immediately. Those of you who were here last year, do you remember these cards? And you wrote wishes on them when we threw them? Remember that? We collected all those cards. We have all the wishes from people last year, wishes in mobile health. We will redistribute them tomorrow. You won't be throwing them around, but we're going to read the wishes, and I'm going to have you work on as tables. How do we take baby steps to make this wish come true? So we have a couple hundred cards here. We'll have them to you tomorrow. So we're connecting last year with this year. Thank you, everybody. It's been a big day. Please thank the speakers and everybody that's helped out. Thank you. Reception's right out here. We'll have live music, good food. Let's keep the conversation going. See you tomorrow morning.